Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindicocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today, I'm joined by my good friend and colleague, Dr. John Kitchens, Retina Consultants of Kentucky in Lexington, Kentucky. Welcome, John.
Hey, Arshad, thanks for having me.
John, I'm so happy to have you here. When I was a fellow, I used to listen to your talks about how to present. You're a great presenter. You know your data well, and you, of course, run your own podcast. So I'm excited to have you as a guest here so we can talk about the latest agents and devices for anesthesia for intravitreal injections. But just like all the other faculty members that come to Retina Radar, John, first, we want to know a little bit about John Kitchen. So tell us how you ended up doing what you do on a daily basis, being a vitreoretinal surgeon.
Yeah, Arshad, it's a lot of my life has been fate and luck and being prepared, I guess, for the right opportunity. When I'll back up all the way to college, actually, it's lucky that I'm a doctor, because when I started out in college my freshman year, I didn't take college as seriously as I should. I went to the University of Evansville, a small school about 20 minutes away from where I grew up. And I ended up with a 2.8 GPA because I joined a fraternity. I partied a little bit too much. And so that summer after my freshman year, I worked for the maintenance group there, and we hung drywall, we put in drop ceilings, we tore up carpet, tore out asbestos. It's lucky that I don't have some cancer from all the asbestos we removed without proper protection. But it was fun work, and it was, very physically taxing. And at the end of my summer, they brought me into the office, and the manager of the maintenance crew actually said, "Hey, we think you've got a lot of promise." And I had told him that I wasn't the best student, as I'd kind of gone through, but I needed to get serious. And he said, "We think you should drop out of college and join the maintenance crew. And we think in the next 5 to 7 years, you could be the director of the maintenance crew here." And listen, those guys were great guys, and the director of the maintenance crew was a really, good person. But I thought to myself, oh my gosh, is this where I'm headed? And if I don't get serious about this, then I could well end up working on a maintenance crew, and being one of those people who always said I could have been a doctor, but I just didn't apply myself. Now, also between my freshman and sophomore year, I met my future wife, and that helped to kind of settle me down and get me in the right mindset of doing it. And so after that year and at the beginning of my sophomore year, failing out of organic chemistry, I got serious and ended up making up a lot of ground in the ensuing 3 years and graduating with a good GPA and good MCAT scores and getting into med school. Fast forward then to the end of med school, and in my fourth year, I thought I was going to do infectious disease. Back in the 90s, we had HIV, we had Ebola coming out. The hot zone was a huge novel that was out, and I was very fascinated by infectious disease. But by fate, I didn't get the right rotation to get my sub-internship on the proper first 3 or 4 months of the calendar year or the academic year. And without a good sub-I, you weren't going to get a good letter of recommendation to get into a good medicine internship. So I kind of threw it out and said, you know what, I'm just going to look at some other stuff. And the first thing I did was an ophthalmology rotation. And I hated it. I absolutely couldn't stand ophthalmology because I was stuck on pediatric ophthalmology followed by glaucoma. And it just so happened by fate that my glaucoma specialist, who I was shadowing, a guy named Luke Cantor, who's a great speaker, great glaucoma guy, was going away to give a talk. And he said, look, on Thursday or Friday, you can just have the day off or go to the operating room. And I ended up going to the operating room and watching Ron Danis, who was a retina surgeon at IU, do surgery. And he actually had a big screen TV up on the wall and was doing a CMV retinitis detachment repair. And I remember watching Ron do that surgery and thinking, this is what I'm supposed to do. Like, this is the most beautiful surgery, and this is what I want to do. And what do I have to do that? So I scrambled, did a bunch of research, and did the best that I could, and ended up getting into the University of Iowa for residency, which was a fantastic training program. The chairman there said I was the lowest ranked person that ever matched during his tenure there. So another bit of fate and luck. And I made the most of my time at Iowa, and really, had a great experience there. And that pushed me on to be a fellow and a chief resident of Bascom Palmer. So that really kind of sealed my fate. And then obviously a lot of credit goes to my mentors, both at Iowa and at Bascom Palmer, for getting me prepared for this, and for speaking and getting opportunities to be on the podium. Carmen Puliafito did a ton once I got out early on in my career to help just kind of promote me and help get me into the spot where I really wanted to be, which was giving talks and presentations.
Wow, what a story, right? A really good story of reaching lows and then reaching highs, right? I mean,
Yeah.
Freshman year to now training at Bascom, the top program in the country, and being a leader in the field. So I think this is a great story, John. And I mean, I didn't know this story, so I'm sure our audience will also learn a lot from it, that as long as you work hard and are motivated, I think you can achieve anything. Okay, so beside being in office and working hard on a daily basis, injecting a lot of patients and doing surgery, what are your main hobbies?
Yeah, so I've got 3 kids. And so I'll tell you also, my near downfalls help give me the idea that it's never too late. So if you've got a son or a daughter that's struggling early on in school or in early college, they can straighten it up and fly right and can turn it around. But being around the kids, hanging out with the kids is a big thing. I love videography and photography, and I love technology. And probably my newest passion is all of the stuff around AI. And I just love the consumer-based AI stuff, what ChatGPT can do, what Claude can do, what AI video can do. I love to make funny videos and other things such as that. So love playing around with AI and doing creative stuff with AI.
Well, then you should submit a talent video for CTS. We have a lot of fun videos, and I think you can beat some of the winners that made it, and those videos are on the website. And obviously, we'd love to have you at the meeting too. So, okay.
We'll absolutely do that, Arshad.
That would be amazing. As long as it's not making fun of me, which all of the videos end up being, I think that's the whole goal. Okay, so let's talk about, you were in training when there were no anti-VEGFs, and then anti-VEGFs came out. It was hard for physicians to kind of adopt monthly injections in the eye, and that happened. And then, obviously the patient perspective of not having pain or having minimal pain with those injections. So tell us a little bit about the strengths and limitation of some of the available long-standing anesthetic agents that you have seen in your career over the last 20 years, and then we'll dive into some of the new techniques that we can use to deliver the injections.
Arshad, it's amazing to think about how far we've come in the last 20 years. When I remember being at Iowa as a resident and having a patient that needed a tap and inject, and we would take that patient to the minor procedure room we would drape them. Sometimes we would gown and glove up, like this was a surgical procedure to just do a tap and inject. And now fast forward 20 years and we just do it in the clinic, right there with the lid speculum and some topical anesthetic and some topical antisepsis, and boom, the injection's in and done. And it's amazing not only that we've been able to advance the field in such a progressive way just by trial and error and learning what works and doesn't work, not only for us individually, but as a profession, but also that we've had new innovations that have come. And so I can remember early on, we worried subconjunctival injections for everybody. We would do lash prepping and we would drape the patient, and obviously a lid speculum for everybody. We would glove up. We would do multiple rounds of topical betadine on the surface of the eye. And that was great, but actually now we've done less is more for these patients. We know that about 0.5% of patients are going to return to the office. And when you're doing 50 or 60 injections a day, that means one patient's coming back every other day with a problem. And 5% of those patients that come back are going to end up having something serious. And the biggest concern is endophthalmitis. So what we have to do is find something that's going to be as safer for our patients, but yet enhance the comfort, particularly post-op comfort and whatnot. And then I think the third key thing, and this is not that we're ever going to have a device for, but just learning things that we can do to decrease that anxiety that patients have around these injections. And that's a real phenomenon. We know more than half the patients have significant anxiety around their injections. And so things like bringing a technician in that can hold their hands, talking to them for a minute before you give the injection, reassuring them, touching the patients. I always like to put my hand on the patient's forehead before I give the injection, just in a way that kind of stabilizes them and calms them. And say a little something before we do the injection, just like, hey, you're doing great. I just want you to look right here and we'll be over in just a second. Little things to try and decrease and diffuse that anxiety. Still is amazing to me that you'll hear patients come back and say, oh, you gave the best injection I ever had. And you think, what difference is there? We're all putting a needle in the eye, but I'm convinced that there are subtle differences that we can all do that can actually help make us individually the best injector that patient's had.
Yeah. So what about, John, you talk about the transition, right? Even outside the US, we actually have doctors taking injections to the OR, which is very, very interesting. But obviously, we are so busy, we do it in the chair. So what about the anesthetic agents that you use currently, and know your overview on different anesthetic agents that are currently available?
Yeah, so we've kind of gone through a cadre of things, and we really do try to customize the anesthesia for the patient. So there's going to be a handful of patients that are going to really need extra. And the one extra thing I think is a subconjunctival injection of lidocaine. So if a patient really has a lot of pain, we'll go to the extra step of doing that. My next step down from that is topical lidocaine on a Q-tip or a swab that I hold on the eye for about 30 seconds to just numb that little area. Leaves a little indentation in the conjunctiva, so when we place our betadine on the eye, you can kind of see where you had touched and held that Q-tip on, and then do the injection through that area. And then for our routine patients, we'll typically use topical proparacaine. There are some additional agents that we've utilized a bit, and it's very interesting to use things. One of them is chloroprocaine, which is a viscous numbing agent. And I do feel that it works better than the topical tetracaine for patients. It's really unique in that it's got a little bit of viscosity. So it stays on the eye. It gives a little greater duration and I think a little greater efficacy for the numbing of the patient. The big concern we have with any kind of viscous material that we put on the eye, and this comes back from years ago when cataract surgeons had increasing rates of endophthalmitis with viscous lidocaine before they did their cataract surgery, is can it block the betadine that we put on the eye? And the nice thing is this does not appear to do that. This appears to work very synergistically with the betadine to actually allow it to still penetrate, to still coat the eye, and to give us that same antiseptic effect, but with a little greater numbing effect. And so we've used that, and I'll sometimes use that for my tougher to treat patients. It's once again has a little greater durability of the numbing. I think it's really good for your dry eye patients as well because of that little bit more of a viscous type material on there. Kind of acts as a little bit of a lubricant for them, and so it can help with some of your tougher to treat patients.
Got it. So it sounds like, we have to cater the anesthesia to what the patients want in certain cases, right? I do have patients, that are okay with the Q-tip, but then, there are patients who don't like the Q-tips and have to do subconjunctival anesthesia. Obviously, the goal is to be efficient and provide safe anesthesia. So I think the topical techniques, obviously, that are evolving from just proparacaine to tetracaine. Some people do just the lidocaine gel, and now having this chloroprocaine gel available for injections, obviously, are all focused on making us efficient and minimizing the pain. So, John, how do you a new patient comes in? Do you just use proparacaine to start with, and then you figure out what their threshold was, or what is your strategy so that our audience can learn from you?
Yeah, so typically what we'll have is new patient will come in and they'll initially get visual acuity, they'll get tone of pen pressure, and at that time we'll use 1 drop of proparacaine for that. Then they'll get dilated, they'll go off to OCT and typically ultra wide field imaging. Then I'll see the patient, I'll talk to the patient. If it looks like they're going to need an intravitreal injection, they'll get another proparacaine drop before I leave the room. And that's also when we'll typically put in, and what we're using now is chlorhexidine.
Oh,
So we'll use some chlorhexidine right after that. Then they're going to get, after I'm out, another like 3 or 4 minutes later, they're going to get another topical drop that's put in of the proparacaine, another drop of the chlorhexidine. Then the medicine's all prepared by my scribes. I'll come in when I put the lid speculum in. They'll give them another drop of the proparacaine, another drop of the chlorhexidine. Then I'll use a betadine swab. And the reason I still use a little bit of betadine is that we went strictly to chlorhexidine for a while. And we just had occasional cases of endophthalmitis. Didn't feel like the rates were quite as low as what we got with when we were just strictly a betadine only practice and we used topical betadine. So a couple of my partners actually use betadine swabs to touch on the eye about 20 to 30 seconds right where they're going to inject before they do the injection. And so I'll just touch with the betadine swab, creates a little indentation and a little brown betadine mark there, and I'll try to inject right through that mark, giving it about 20 to 30 seconds for it to work. And then they rinse the eye out with chlorhexidine, actually. So we're trying to use a combination of both chlorhexidine and betadine to reduce those chances of endophthalmitis.
well, that's pretty cool. I've never heard of that. So, John, do you compound your own chlorhexidine?
Yeah, so our technicians and scribes have a recipe that they go through to compound it, and basically we use it. We rinse the eye out with it. I think it's a little bit nicer. It's very gentle on the eye, so you don't have the irritation that you typically have with betadine. And I feel like when you rinse a patient out with BSS, you might stir up any potential bacterial flora that's in the conjunctival cul-de-sac. But if you're rinsing with chlorhexidine, you're actually rinsing with a solution that has kind of an antiseptic effect.
Wow. I may need to get the recipe from you because we have a lot of dry eye and irritation in Reno. So have you seen, one last question before we move on, have you seen patients complaining about less irritation with your combo strategy of chlorhexidine and betadine?
Yes, certainly compared to just betadine as a topical drop that we would give, and we'd give it in kind of the same interval, a couple of drops of a betadine solution on the surface of the eye, and then another drop of betadine right before we give it. Absolutely less patients coming back with ocular irritation, less corneal abrasions, and less corneal toxicity.
Wow. Okay. Well, I'll get that recipe from you for sure, because I think that's a really good idea to combo and find the right balance so you don't increase the rates of endophthalmitis, but also improve patients' comfort. So, John, another addition to our toolbox is non-pharmacologic anesthesia using a cooling device that's now FDA approved in patients who are allergic or cannot tolerate, pharmacologic anesthesia. And obviously I was involved with the program, but it's nice to see, that we now have a device for anesthesia instead of all the drugs that we talked about. What do you think a device will fit in your clinic, which only takes, 10 seconds at minus 15 Celsius? So you put a proparacaine, betadine, cool the eye, and then put another betadine and inject. What do you think is value for that treatment in your clinic?
Well, Arshad, I'll tell you, it's really unique and novel to have somebody thinking so outside the box to realize, hey, wait a second, this cooling effect is real and really does work. And I'll tell you, I've not played around with this. I would love to play around with it because I think it's so novel. And first of all, very quick. It's going to work very quick. I'd love to garner some of your experience from it, but I'll tell you, the validity for this really comes in my mind from what I tell patients who complain about burning with their eye drops, particularly glaucoma drops or even steroid drops. And I was told by a dry eye specialist that if you ever have a patient who has issues with the drops burning, tell them to put them in the refrigerator and get them cold. Because when they hit the eye, they will hit those temperature sensitive nerve fibers before they actually hit the pain fibers, and you will get a sensation that's different and less uncomfortable. And I found that actually has been very effective for patients with their topical drops. So extrapolating from that, I would imagine that this actually works. But you tell me, Arshad, what's been your experience? You were the first to use this, I think, in the US, right?
Yeah, we were part of the original studies, the Cool One, where we were the first site to use it. And I'll tell you, like since that time, about 5+ years ago to now, the device has come a long way in terms of just how it looks, how you can handle it is much more user friendly there. And then we were doing different temperatures and different times in Cool One and Cool Two studies to optimize how much cooling we need and for how long. Because, you can imagine if you're cooling for too long, patients will have discomfort. If you're not cooling long enough, the effect is not there. So I'm glad you mentioned cooling the eye drops, because the idea of this came from like just putting an ice cube on the eye, right? I mean, so what you want is you don't want like a cryo effect where you're damaging the conj and tenons in that area and going too deep versus deep enough that you actually have no pain. So yeah, we learned over time that minus 15 degrees Celsius was the right temperature. And then in terms of the time, 10 seconds was the optimal time. I think past 10 seconds, patients were actually getting discomfort from the cooling aspect of it. And when we were doing these studies, many of the patients, John, we switched in the study were patients who were on subconj. And obviously, subconj is gold in terms of zero pain. But we saw minimal pain with cooling. But the interesting part was that around 80% of patients preferred the cooling device over subconj. And we were asking about their experience in pain, obviously during, after, and then the next day. So I think the patients had less irritation, and they had less discomfort post with it. So that's why I think it's a very good option to consider. And obviously, it's not for all patients, but a good number of patients can benefit from it. And the other thing it brings is obviously efficiency in your clinic, that you can put the cooling device for 10 seconds and then inject. So I think it's a very good advancement, as you said, to move away from pharmacologic anesthesia, and obviously was recently approved, and we will see more uptake of this in the future. But I'm glad that you think that there's clearly some role for it, and I think it's more about learning experience too. Like, now it's so simple, and it gives you different signs and beeps and other things that exactly that you are touching the eye. It's been 10 seconds. So yeah, very exciting development here, John. Any questions from your perspective about it?
No, I have. Once again, I haven't used it, but I look forward to trying it. I think it solves two big problems, Arshad. Number one, if you're doing, first of all, you're right. The gold standard for pain-free injections is a subconjunctival injection. Like patients, that is the one thing. If you have a patient that just hates the shots, can reduce their pain by up to 50%. So if you can approximate that, that's huge. But the problem with the subconjunctival injection workflow-wise is it's 2 trips into the room. You got to go in and give the subconscious, and then you got to let it work. And usually I'll leave the room and go do another injection or 2 before I come back in the room and inject. And then you got the red eye issue. So if you think about it, 10 seconds of this on the eye, if it can even come close to a subconjunctival injection, it has 2 real values: the enhanced workflow and then the lack of subconjunctival hemorrhage, which is one of the about a third of the reasons why patients come back to the office is they've got a big red eye when you hit a blood vessel. And I do that more often than not when I'm giving a subconjunctival injection.
Yes, or you just tell them that you have a red eye now, don't come back, and just tell everybody it was me, right? So I try to come up with different jokes when we get it. No, definitely. I think, so I think this comes close. So I don't know if anything can beat subcon, John, but if you can have a little bit milder increased pain compared to subconj, but you have much less irritation post, and 80% preferred it. So I think it's for patients who don't like some sort of pharmacologic anesthesia to try this device. Okay, so really, really good discussion, John. We are coming towards the end of the podcast. So I always ask our faculty member a few more questions, and the question for you, just like everybody else, is tell us about your career achievements, especially the one you're most proud of. I don't want to dive into the number of awards you have won or the Oscars for the surgical videos that you have won. So everybody knows you really well. I mean, you have won so many awards, but tell me the career achievement you're most proud of.
I think probably the biggest thing that I'm most proud of is our fellowship program. And our practice has a collaborative fellowship with the University of Kentucky. So fellows who come in and train for 2 years, they train in surgical diseases, primarily of the retina. They get exposure to an academic institution, so they get to see the academic side. They get exposure to a private practice side. We have, 3D heads up surgical everywhere that I operate at, which I think is huge for training the fellows. We get a chance to work with some of the newest equipment from a surgical standpoint. But really the rewarding thing is having in 20 years trained so many great surgical retina fellows. And our fellows will routinely come out of here with 800 to 11 or 1,200 cases as a primary surgeon. And I tell them, listen, the one thing that I know whenever you leave this program is that you're going to go to whichever practice or whichever community, and you're going to be an incredibly good, efficient surgeon who's going to be able to take great care of patients, and you will never stress over being in the operating room. And so knowing that we've put out now, we do 2 1 year, 1 the next. I've probably been involved in about 40 different fellows training and coming through here. And so to see them go out and achieve great success gives me a lot of pride. And a lot of them are still great friends of mine. I see them all the time at meetings and talk to them, and occasionally they'll reach back out with questions or whatnot. And it's I think the thing I'm most proud of professionally.
Yeah, no, I mean, I think that's something that is very hard to get in the fellowship world. What you have created. I actually interviewed at your program a long time ago too, and everybody said John Kitchens is a super surgeon, and you want to train with him, and rightfully so. And the volume you said is enormous. I mean, this is one of the highest volume programs in the country. So yeah, you should be very proud of it. I think, you know, I've trained, a few fellows, not as many as yours, but I think what you realize is that the impact, you can multiply the impact you are making, right, for patients more on a global level by training the next generation. And I'll tell you, I mean, friends that I have that have trained with you are amazing surgeons. So that kind of reflects upon the commitment you have, John, and you should be very, very proud of what you have achieved. And everybody I speak to always say nice things about you. You know, some programs you go to and, oh yeah, it was a great program, but that guy was just not nice in the OR. So I don't think that's the case. I think, if I was doing fellowship again, I would love to have you as the mentor because you bring that positive energy and really great personality. So, John, thank you for doing what you do now. You have a long way to go, but how do you want to be remembered when you retire? That's the next question.
Boy, these are hard questions, Arshad. I think the thing that I would want to be remembered for is like you had just said, being a positive influence on people and on the profession, trying to find win-win ways. And I'll tell you, and you do this incredibly well, is making people better. Like when you interview me, you make me look better. When I'm on a panel with you or something, you make me feel better and feel smarter about what I'm doing. And I learn a lot from you. Your research is absolutely incredible in the way you present it. And I think people need to realize when you work with industry, okay, and you and I both work with industry, research, consulting, speaking. When you work with industry, it's got to be something where you don't do it for the money. You do it because you want to help people out. You want to help them with their messaging, their education, and look for ways that you can, in all of your relationships with industry, with fellow doctors, with patients, it needs to be something where it's a win-win, and putting other people as a priority and never putting money or financial gain as the reason why you're doing something. You got to do this because you love it, and then that I think will absolutely shine through.
I tell you, that's exactly how I remember you. You are passionate, you are scientific, you are nice to work with, and you're always thinking outside the box to innovate the field. So John Kitchens, thank you for the excellent discussion and coming to this podcast. It was an honor speaking with you today and learning about the intravitreal injections that we do so many of them on a routine basis. And I also want to thank our listeners for tuning in. Thank you, John, again.
Thanks, Arshad.
To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindicocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.